You return back to Boyle's law here because it underpins everything that follows. Pressure, remember, varies inversely with volume when temperature and gas quantity are constant. During ventilation, changes in thoracic volume are translated directly into pressure changes that move air. And this is not conceptual, this is the physical meaning of breathing. The slide emphasizes that gases always expand to fill their container. When thoracic volume decreases, pressure rises. When volume increases, pressure falls. Ventilation depends entirely on these small but precisely controlled pressure gradients. Without a gradient, airflow stops. This again is showing some relationship building between intrapulmonary pressure here, this pink line, interpleural pressure here, this kind of brown line, and volume of breath here, this blue line. And then our relationship with our atmospheric pressure. Note how small the pressure changes are here, specifically in intrapulmonary pressure, only 1, maybe 2 millimeters of mercury maximum, and that's sufficient enough to move air. This efficiency depends on low airway resistance and an intact lung chest wall coupling. That leads us into the physical factors that influence pulmonary ventilation. There are three factors that can determine how easily the lungs can ventilate: airway resistance, alveolar surface tension, and lung compliance. And from this point forward, each slide is going to unpack one of those factors and show how pathology can alter them. Airway resistance is the friction that opposes or is opposing airflow. Under normal conditions, resistance is minimal, which is why small pressure gradients can be sufficient to move air. In disease, though, resistance can increase and dramatically change by increasing the work of breathing. Flow is inversely proportional to resistance, meaning that the higher the resistance is, the less flow there will be. This is a key relationship for understanding obstructive pulmonary disease. Despite their small size, terminal bronchioles contribute little resistance because total cross-sectional area in our terminal bronchioles is enormous. The greatest resistance actually is going to occur in our medium-sized bronchi, making them the primary site of pathology in asthma and in chronic bronchitis. Another component that can affect ventilation or airflow or movement is alveolar surface tension. Surface tension arises at the air-liquid interface in our lining of our alveoli, each individual sac. Water molecules are attracted to each other and they can hydrogen bond with one another. This creates a force that favors alveolar collapse. The inward force has to be opposed to keep alveoli open, especially small ones. And that's where things like surfactant can help. In Laplace's law, it explains why small alveoli are more prone to collapse. As the radius, seen here in R, decreases, the pressure required to keep the alveolus open increases. Without a compensatory mechanism, ventilation would be mechanically unstable. So the smaller the radius, the larger the pressure required to prevent collapse. That's Laplace's law. Lung compliance describes how easily the lungs expand in response to pressure. High compliance means little pressure is required to increase volume. Normal lungs are highly compliant due to elastic tissue and due to surfactant. Speaking of surfactant, we mentioned it already once, but surfactant reduces alveolar surface tension, stabilizing alveoli of different sizes and preventing collapse. By lowering the pressure required to inflate alveoli, surfactant dramatically reduces the work of breathing. Compliance of the lung is defined as the change in lung volume divided by the change in transpulmonary pressure. Diseases that reduce compliance, such as fibrosis, make breathing stiff and energy costly. Compliance depends on two elastic forces: elastic fibers in lung tissue and surface tension within our alveoli. Alterations in either will shift the pressure-volume relationship, as seen here. So the lung compliance curve, kind of like our cardiovascular curves, illustrates how lung volume responds to changes in pleural pressure. Early inspiration, seen on this kind of initial portion here, requires more effort due to alveolar recruitment. As volume increases, though, compliance improves until elastic limits are reached. And so we can see here that early inspiration takes the most work, and then compliant, then at the end of inspiration, it's less, and then vice versa in expiration. Compliance can be reduced or diminished in conditions such as pulmonary fibrosis, surfactant deficiency, or decreased mobility of the chest wall. These patients breathe with rapid, shallow patterns to minimize work of breathing. And we can see here, this is showing the pressure volume relationship during inspiration and expiration and how the elasticity of the lung can affect that. The inspiratory and expiratory curves will differ due to hysteresis. More pressure is required to inflate the lung than to deflate it. And this is reflecting elastic resistance and surfactant dynamics. This explains why expiration typically is passive. It's normally a passive process. We're going to stop here. When we come back, we're going to talk about some things that help us assess how well we're ventilating.